Tatsu mentioned, on to Aaron. Aaron Turner is currently employed as a critical care paramedic by the largest ambulance service. I'm going to say New Zealand, Aaron, because I can't pronounce that name. I'll let you pronounce it. I don't want to cause any offence, but he works primarily on one of two rapid response units in Christchurch as a single responder, serving an area of 12,000 kilometres. He holds a specialist portfolios in cardiology, trauma, as well as HAZMAT response, and is a contributing member of the Australian College of Paramedics. Aaron, welcome.
Cheers, guys. Hopefully everything works. We're lucky last. All right. Has that come up for everyone?
So I can get you loud and clear. Yeah, we've got I'll hand over to you.
Fantastic. Hey guys, lucky last on the group. I'll try and make it short. It's a reasonable time here in New Zealand. It's just coming up to midday, so it's quite civilized for us. For the rest of you guys, not so much. As I've been introduced, I'm going to be talking about the critical care model within Aotearoa, New Zealand. And I think piggybacking on a bit of what Tatsu said, hopefully I'm not going to repeat too much, but we'll see how we go. So a bit about me. I've been down here for about 6 years now. I'm originally out of Tamakima in Auckland, where I worked for about 4 years. So a few pictures just to make you jealous of the landscape that we have down here. Some beautiful sunny days. Not all the cases, actually pretty miserable today, but I won't turn the video around to show you that. Bit of an orientation, really. We've had a few already from the rest of the other presentations, but this gives you a bit of context as to where we sit with New Zealand. So we've got a population of 5 million people spread across mainly 2 islands, the north and the south, and a general life expectancy of around 82 years. The issue that we have is we don't necessarily have full equity within our population. So the Indigenous Māori population only have a life expectancy sitting around 75. And similar for a lot of our Pacific Island communities as well. We do have a large amount of Pacific Island people within New Zealand. We have more Samoans than Samoa, more Tongans than Tonga, because a lot of them come here for work. So there is a lot of health inequity that comes across with that process, and New Zealand is trying hard to change that. However, it is a long process. With the split across the country, the yellow line on the map there actually indicates the halfway mark for our population. So everyone north, or half of our population is based north of that line, and then the rest of half of the population is based south of it. So we've got quite a sporadic placement of density within our population, making urban, rural and remote work quite challenging for the ambulance and the helicopter service. We've got large environmental risks, a lot of flooding. We're getting quite a few earthquakes recently. The Christchurch earthquake is one of the ones that is of recent mind. However, our main fault line that runs up the entire country is set to go within my lifetime, and that's up to a magnitude 8. So there's a lot of planning going around that at the moment. And it goes to show the sort of environment that we're working in. Up the top in Auckland, we've got about 1.6 million people based there. In Wellington, we've only got 200,000. Christchurch, where I work, is 370,000. So quite a spread across those centres. Bit of brief comparison for you guys. Looking at Australia and Canada, we're always going to be dwarfed. Understanding that we have 5 million people, Australia, 26, Canada, about 38 million. However, when we start to look at South Africa as well as the UK, we can see size-wise, we're a bit more on par. However, population-wise, with South Africa having 60 million and the UK 67 million, we have to provide a service over an extremely large area with less funding, I guess, for a population that's very, very diverse. We don't have any privatised ambulance services within New Zealand. We have 2 primary services. Hato, St John, covers the majority of the country of the North and South Island. And going back to DHB systems, Wellington Free Ambulance Services, the Wellington region, which is highlighted there, as well as the Wairarapa, the Kapiti Coast. Because my main employment is through St John, I'm going to be primarily speaking with obviously a St John centric lens. So I do apologise for anything from Wellington Free that I do miss. Tatsu has indicated our clinical guidelines already. It's quite a unique thing that we have a national set of guidelines that encompasses the entire service, both the helicopter service and the frontline EAS system. The QR code will take you to that link there, and it's based around discussions between the medical directors of both services as well as all three helicopter trusts. So quite a collaborative approach, which is fantastic. Because we are so small, it does allow us to actually have a relatively unique set of guidelines that is changing in response to the current literature, and we can change it relatively quickly and trial things pretty smoothly, which is great. Tatsu alluded to this earlier. We have a HEMS model spread out around the country. Their bases are highlighted there, showing a relatively good coverage of all areas. And this is dispatched by St John under contract by the Ministry of Health. And this allows for the calls to be received and dispatched by the same organisation, allowing continuity of care. We have a large reliance on volunteers within the service. This is a long-standing contribution that they've been given. And so we still run quite a large amount of internally run courses. And through that process, our volunteers are able to reach a level of emergency medical technician. If they wish to progress any further, we're entering a postgraduate and undergraduate pathway. So a 3-year degree through 2 of the institutes here in New Zealand. We've got Aotearoa out of Wellington or AUT out of Auckland. The 3-year degree warrants a level up to paramedic. However, when you enter the service, you undertake an internship process of 6 months. And then you have independent practice after you pass a clinical assessment day. And that assessment day incorporates a scenario, a viva voce in front of a panel, as well as a skill station set of 3 tasks. And after that period, you go straight into being a paramedic. There's no further assessment. There used to be, however, that's been streamlined. If you wish to progress further after that point, undertaking your own study, it's 2 years through an advanced resus diploma. Some people do progress on to master's level. You're then allowed to enter into your intensive care paramedic internship, which is 6 months mentoring on the road before your CAD day, and then progressing further through case studies and then having a final discussion with the medical directors. And that will allow you to achieve the qualification of intensive care paramedic. The final qualification of critical care paramedic that we have is a grey area at the moment. We're currently in a flux and a transition zone between ICP and CCP, whereas the CCP role on paper only adds rapid sequence intubation. And the move at the moment is to disestablish the ICP role and primarily have CCPs, and I'll talk to more of that shortly. So historically, as I said, the ICP model has just had RSI endorsement above that. However, with the disestablishment of the ICP, we now have CCPs primarily orientated in rapid response vehicles, where historically ICPs were also based in ambulances around the country. And there was no clear placement of these individuals. And with the CCP model, we're now currently looking at job load and skill retention and where they should be placed primarily. Also, with the move towards a critical care paramedic model, they're understanding the actual requirements for someone to stay competent at that level. And the emphasis now is on operations for these individuals, with a very limited number still sitting within the clinical support team, such as sitting on our clinical desk to aid our crews through phone triage, as well as video calling to scene and supporting staff on scene who may need to take out of scope procedures to ensure effective patient care. So looking at our split around the country of our CCPs, we can see the cars indicate the spread. Now, understanding that there's a single car based around Tamaki Makaurau and Auckland. However, they have more than that just within that small area. In Christchurch here, we run two 24/7 what we call eco units, and I'll show you those shortly. We also have one 12 by 7 eco unit as well. Some of the other ones, such as Nelson, which is at the top of the South Island, runs day only eco unit, and at night either unavailable or currently based on an ambulance at the time. If we then superimpose over the CCPs available by the helicopter, we see a relatively good coverage nationwide, which allows for obviously ensuring a level of equity of healthcare access to all of the public. We do have an area within the sort of the central South Island, which is quite a large gap. However, the population through there is pretty scarce, as well as the central North Island. And being serviced by helicopter allows for that to occur. Unfortunately, the whirlybird doesn't like to fly when it's a little bit wet. So quite often road-based resources do need to head for long distances into those areas. We've already touched on the clinical practice guidelines. They're all electronic now in app form and freely available to anyone that wishes to read them. On the left here is our old CPGs, which are currently in the process of being updated to the ones on the right. Really user-friendly. They've put a real emphasis from a CCP perspective for it to be guidelines, and nothing is necessarily set in stone. As a senior clinician, if I can justify the use of a drug out of the context that it's listed in the procedures, and I deem it safe to do so, I can, as long as I then either flick the item for auditing to ensure that it is checked, and I have a debrief with the medical director at a later stage. We're given a large level of autonomy, which is quite unique to New Zealand. We have the ability to undertake RSIs with most of our patient cohort. We've just recently been asked that anyone under the age of 5 and over 70, we do consult because these are high risk groups, and also for the elder group, ensuring that it is appropriate for them, understanding the current pressures on our ICU system. Over the last couple of years, we've had quite an increase in the amount of drugs that we have access to. So we're up to, I think, 45 drugs now, and you can see them all listed on the right-hand side. Some of them are currently not necessarily in use full-time from a frontline perspective. The likes of metoprolol, labetalol, GTN infusions are all primarily based within ICU retrieval setting. And because it is a national set of guidelines, they don't always work for St John. It may be Wellington Free wanting to still have access to a couple of drugs. CPGs in general seem to have or be influenced by opinion a large amount of the time, especially when you get 8 doctors in a room. They all can't seem to necessarily decide on what single drug is the best one. We recently, or probably 5-6 years ago, moved away from morphine. We're now sitting with fentanyl and ketamine. And a lot of these drugs are actually still available at paramedic level. So as a CCP, what I bring to the show is more of a clinical oversight and a few extra skills, which I'll show you shortly. And with that, our paramedics are actually empowered to do a lot. So they can give ketamine for analgesia. They're allowed to sedate under certain circumstances. They will can, through guidance of the clinical desk, if they are remote or rural, actually look to sedate for cardioversion and do a number of other tools. So to be honest, the bulk of our workforce with paramedics do a fantastic job, and we're just there to support them, do paperwork and do the heavy lifting, which is, again, very rare. A couple of the skills that sit within the CCP scope at the moment. We've recently got the ventilator, which allows for CPAP and IPPV ventilation settings, which is a game changer in many respects for us. The CCP holds intubation, looking at RSI, DSI, and of course the truncated or crash RSI, depending on how you want to talk about it. The old tension pneumothorax can be fixed with either needle or finger thoracostomy. And we've recently moved to the lovely agricultural system that the HEMS in Sydney have published. It's a bit more brutal, but does a pretty good job. Of course, we've got crike pacing and FI block, which is a little unusual. Usually in ED, they're doing it under guidance of ultrasound. Here we're doing landmark orientated for primarily a broken femur or a neck of for a NOF, with usual great effect given our long transport times. And another one being procedural sedation. I've also alluded to the fact that we bring a level of clinical oversight and hopefully clinical excellence to the scene to allow for CRM and enhanced clinical reasoning. The whole move to the CCP model has been an emphasis on bringing a package of care. And with that, we've got a new vehicle, and we're currently running out of the Toyota Hilux, which is probably due for a refit and a redesign soon to see whether or not it's actually fit for purpose. What we've got here is an emphasis on all the gear being based in the back of the cab. So ideally, even your personal gear is in the back canopy, and that is purely for a safety perspective, ensuring that if there is an accident, there's nothing kept within the cab itself. On the passenger side, this is where the bulk of our operational gear is kept. Everything is now in a modular form through NEAM's module system. Sorry, NEAN, which is an Australian outfit, and everything's color coded. So the yellow there is our intervention and our drug modules. The green is the airway. The blue is our bag mask system with LMAs. The red is sort of our assessment bag and holds our trauma gear as well. And our green bag down the bottom right there is our oxygen in a padded case. Anything that requires electronic charging is plugged in. So the Lucas device, the suction, ventilator, and syringe drivers are all plugged in for real-time charging, which allows them to be used for long periods as soon as they're pulled out. On the other side, we have our stream lights. I think this is, for me personally, the biggest addition to our portfolio is the fact that I can now bring lighting to a scene. Our fire service don't necessarily have lights available at the time, or we may be working in isolation, and we don't necessarily need to pester the fire service just to come along for lighting now. We can actually do that ourselves. On the side as well, we carry our crush kits, our sodium bic and calcium chloride. We also carry STEMI thrombolytics kits for undertaking thrombolysis prior to transporting the patient for secondary PCI if needed. And the rest of the gear on the side is aimed at the ability to restock an ambulance at a scene if we back them up with the potential for them to be available immediately. The whole point here is to decrease turnaround time for our ambulances. One point of interest, of course, is the stab-proof vests, which have been included. These are a relatively new addition post the outcome of March 15, 2019, which was the largest terrorist incident in New Zealand, where 51 people lost their lives due to a single individual. A reflection was done on the ambulance service showing that our capacity for ensuring a level of staff safety in a maraudering attack was actually nil. We have specialist paramedics and CCPs that work with our AOS team, with our STG groups, and they are trained in ballistics. However, the majority of our staff are not, and this was hopefully in an effort to allow a level of protection should that situation change and happen again. Each echo unit carries a full range of vests available, and it's usually just for the people working within the warm zone. Secondary to the March the 15th, we also carry a 10-person MCI case in the back. So this is available should a maraudering attack occur again, or whether or not it's any MCI from a multi-vehicle incident or a festive concert event, which isn't necessarily resourced. So we're able to take this to the scene immediately, drop it off, and have staff work with IV gear, oxygen gear, fluids, and trauma equipment for up to 10 people. The emphasis on the package of care brings a couple of fun toys to the party. One of them being the Weinmann ventilator, which it only has at this stage set functions for CPAP as well as IPPV. And I would love to have BiPAP. It's one of the biggest things that I'm looking for. However, the move towards this allows that, if I'm transporting an ICU intubated post-ROSC or an RSI patient for a number of hours, I can do so safely by myself in the back with that setup. The drawn syringe drivers, absolutely love them. They take a little bit of getting used to and can be quite technical. However, it does, as I said, allow us to treat these patients over an extended period of time, giving them an accurate drug dose, which may not sound too important. However, if you're giving boluses of sedation post-ROSC, it's never great from a hemodynamic stability point of view, and giving them over a slow infusion is a much better way to control it. The McGrath video laryngoscope is our next option, and this is used in the majority of our intubations these days. We still try and keep skilled at DL as well, but this makes the increased safety. And if we are doing an RSI, the standard model is for a double CCP mix to be present, and it allows the airway assistant to visualize the process as well, so we can actually guide each other through that. We also have the Lucas mechanical CPR device. This is an addition, it's a tool. It's no better, no worse than actual normal CPR, but what it does allow in an unstable ROSC patient, we can set it up on the bed in the ambulance to allow for rapid CPR, safe CPR in a confined space. Also, if we are slightly resource poor, it allows us to do prolonged resuscitations if appropriate, I might add, without tiring our crews. All of these equipment are only available on the echo unit. Something that is unique to our crews is our ability to have real-time monitoring of jobs in our area. So our echo staff, or CCP staff, have access to VisiNet, which is a backdoor access into our communication system. And we can look at our pending queue of all of the jobs that are present, as well as our assigned queue to all of the jobs that are actually assigned to vehicles on the road. We can read notes that have been entered by the call taker. We can read notes from the police and the fire service. We can also read notes from our clinical team, who may be in discussions with the crew on scene, or getting extra information from historical jobs that have attended at that address. When looking at these jobs, we can actually self-assign. So I'll radio up asking to attend a job that Christchurch 4 might be at. And while I might not necessarily be adding a level of clinical oversight, I may be going purely because they are a very brand new crew attending a cardiac arrest for the first time. The patient is obviously well deceased, but they might need help with their paperwork. So the CCP role is not necessarily purely a clinical role, it's also a staff support role from a clinical aspect, and ensuring that our staff are obviously well supported in that role. Another tool that we have is real-time monitoring of where our vehicles are. So we're able to see if the vehicle's AVL is working. It's not always. You may see a unit in the middle of the ocean traveling at 400 kilometers an hour, but generally it's relatively accurate in understanding where our units are. So if I am first responded to an incident and I am requesting a crew to back me up, I'm able to ascertain where that crew is in real time. And if a more higher priority job comes in, they'll obviously be released, and it gives me a bit more of an understanding of our resourcing. It also allows, with multiple units on at the same time, if a job is not in my patch and over towards another echo unit, but they may be having a meeting or doing something else, I can give them a call and just see if they're aware and if it's something that they want to look into. So constant communication between echo units, especially within my area. Very lucky that we do have a couple, is quite good. Something that is unique to the South Island is if you're a registered paramedic, you have access to what we call Health One, which is our patient database. So through this process on scene, I can look up all discharge summaries from ED, I can look up assessments from hospital, I can look up recent blood tests, any history, I can look up CT scans or sonography results, and I can look up what the GP has prescribed. And this is only useful in the South Island at the moment. I understand it will eventually go nationwide. However, IT systems between each district have been quite prohibitive to that being the case. I could not live without this process. It also really allows us to look at how our patients progress. So through an agreement, we are able to look at patients up to 2 weeks post their admission. So I can follow a patient through their care from, if I've intubated them from post-ROSC, I can see what's occurred in the cath lab. I can look at the doctors and cath lab nurse notes to see what was stented. I can then see them into CCU, their bloods, their troponins. I can then see them through into the ward, and then I can see their discharge home and follow-up, which is invaluable in allowing that sort of circle of closure for all of our patients. We often don't get it, so that's something that's really unique, especially within Christchurch. Recently, a lot of our staff have been doing some further training. So the four-wheel drive courses have been running towards the later part of this year. It's all been held off due to the lovely COVID. I haven't done mine yet, but people say it's an absolute blast when you're taking a work vehicle out and you can absolutely smash it, destroy it, or do whatever you want, as long as you bring it back in one piece, I guess. Our continued clinical education has started back up again. So all of our CCPs are able to sit down with a doctor. On the left-hand side, the guys are going through finger thoracostomies. And as I said, we've gone to the more aggressive agricultural technique of it, not a simple poke through the ribs, but running it up and down and making a much larger incision area. And it gives us a chance to just debrief and talk about ventilation strategies, or what's working, what hasn't, what our role is in supporting our staff, and ensuring we get the best for the patient and the best for our staff as well. We do go through advanced resuscitation forum discussions online. So every couple of months, a couple of cases are presented. We have our medical directorate on board at this time, and when the cases are presented, we can then debrief and go through each aspect of what worked, what hasn't, and it's a fantastic chance for staff to sort of just make themselves a little bit vulnerable. It is difficult to present in amongst your peers, but it's highly important because we do go to a lot of high acuity work, but with low frequency. So this is just part of that process, is ensuring that we support each other. Each region often does its own thing as well. In Christchurch, I'm very lucky to be supported by a very proactive group of CCPs. We have our own sim suite downstairs that we can have access to should we want to book it. And on Redwatch, which is what I operate on, we have 4 or 6 CCPs. So we often debrief on a regular basis after a job at the end of shift over coffee, or we just text each other for a catch up. So that's fantastic. In the next year, we're looking at the potential for undertaking sort of informal clinical and professional supervision amongst ourselves, but in a more sort of formalised aspect, I guess, to ensure that, yeah, we support each other, but do so in the right way. A new addition coming to us at the moment is the Oxford lifting pillow. Our RSI stats, I understand, are quite good. I think we're at the first pass success rate of around 93%. I don't have the stats on me right now, and I think a successful RSI rate of around 98%. And with the Oxford pillow, I hope that will just allow for better positioning and hopefully better numbers. A nice addition to the tool resource, I guess. In the future, we're kind of looking at blood, as we all are. With the refill trial, it's made it a little bit more complicated. The New Zealand Blood Service still maintain that it should primarily be a doctor-led medication and a doctor-prescribed medication. So therefore, there is a hold up on that aspect. That's something for the people paid more than me to work through. Point of care ultrasound sits as currently being trialled with our extended care paramedics. So these guys work in the low acuity environment by themselves and do an absolutely fantastic job. The role within the CCP environment is a little bit more cloudy and needs to answer specific questions rather than be an investigative tool. And we'll see where that goes. It's probably within the next 2 to 3 years for us. Love to see BiPAP come on board with increased ventilation strategies, and some of the tools overseas for point of care testing are absolutely fantastic, and I really do hope to see those come through with us very shortly. The last thing I want to say is that it's not all doom and gloom around the world at the moment. This was our ED in probably about 1 or 2 o'clock this morning. With only a single ambulance present. The ramping times in New Zealand are only 33 minutes, and then we're out and about again. So look, guys, if you're wanting a job, come over here. That's me, guys. Cheers.
Aaron, I don't know whether you'll get people because there wasn't many pictures of the countryside. And
I can easily put some up. I actually deleted some.
I know New Zealand's stunning.
Hey, look, from where I am, I'm 20 minutes to the beach. I'm an hour and 20 minutes up to the ski fields. So it's fantastic.
Aaron, one sort of burning question that I've got to come through is one burning question. Your scope of practice is huge, absolutely huge. How do you maintain that scope? Do you keep a log and do your own CPD? Because if you were taken off the road, you'd be off for 6 months.
Yeah, I guess it's down to the individual, and like any workplace, you get competent ones, you get ones that the crews try and avoid. Unfortunately, that will always be the case. It really much comes down to the individual, and you talk to a lot of the paramedics who are looking at coming up to the critical care level, and a lot of them are put off by the fact that it is, once you're there, it is constant. Whether or not it's understanding the current foam articles, listening to podcasts, undertaking Realtime. It varies. The luck that we have, I guess, is that at the moment, I'm probably busy about 40 to 50% of the time. So our utilization is relatively low, and that downtime is then spent keeping my skills up. Some of the lower, more remote CCPs, their utilization might be only at 5 to 10%. So there's a real push at the moment to ensure that they are engaged, whether or not it's through auditing or taking on high acuity portfolios, just to ensure that they are not sitting there watching the chase and actually doing something productive. So yeah, it takes a little bit of work, and you've got to maintain a level of motivation.
Absolutely brilliant. Listen, Aaron, conscious of time, thank you ever so much for joining us on an absolutely brilliant presentation. Thank you ever so much for that.
Cheers, guys. I saw a lot of questions, and I will work with Steve to answer them later on.
Yes, what I'm going to do with the questions is ones that haven't been answered through me posing them or within the panel. I'm going to collate them all and I'll send them out to the respective regions. Obviously, naturally, it's going to take time. We've got Christmas around the corner, so they'll probably be in the new year before we start feeding some responses back in. So we finish where we started. We come back to the UK. We've travelled to South Africa, Canada, Australia and New Zealand, and we come back to the UK. So what I'd like to do is I'd like to welcome the chair of the International Critical Care Group, Christian Wiggin. Christian first approached us back a while ago. Christian approached us a while ago about doing this symposium, and between myself and the team at the college, we've done this 4-hour epic journey around the world, Christian. So I will hand over to Christian for closing remarks.
Guys, hi everybody. It's been a tremendous symposium. I've got written here a few things about what I'd just like to say, but the one that stands out is quite humbling. There's such amazing practice and inspirational speakers from all around the world that I want to do it again. I always want to learn more about what everyone else is doing in different regions. My phone's been on fire with people saying, right, when are we going? When can we go? What can we do? And it's just tremendous that there's so much enthusiasm out there. We've got literally people from all over the world who've been involved with this, and it's I'm just delighted to be a part of it. A few thank yous again. Thank you to the speakers. I mean, just describing the scope, the practice, challenges, the research that's going on, the governance that's underpinning it all, just kind of really hallmarks what is a progressing profession. And that profession, obviously, being paramedicine, it's just such an inspiring place to be at the moment. For me personally, I've been in it for 20 years or so, but it really feels like the world genuinely is opening up at the moment. Thanks to the participants as well. There's been, as I said, people from all over the world getting involved with this, and that's the whole point of this symposium, is to reach out to every aspect. We're not representing everyone in our international critical care group at the moment, and we want that to change. We want to get people from all over the world getting involved with this as well. So everyone's got a voice, really. So what about the future then? So from a international critical care group perspective, we represent quite large areas, but there's still huge swathes of the planet which aren't represented on the group, and we want to expand our membership to include that, so we can do what it says in the tin, really, and be a true international critical care group. How do we do that? Unrepresented areas of United States, Africa, Asia, Europe, South America. There's huge swathes of the globe that aren't represented, and I keep talking about it, but we want to reach out to those people. So please get our contact details and get in touch if you can. What do we do? So I've had people suggesting a website. That'd be awesome. And possibly a future symposium, maybe an annual symposium would be great. And we've had a Monash University from Victoria in Australia, like suggesting that it might be an option to create a symposium in one of their outposts in Italy one year, which maybe 2024, which might be something face to face would be quite an incredible thing to look for. And hopefully next time this will have subtitles down here as well, so that we truly are representative of everyone. But I guess the final message for the whole symposium is to everyone out there, like all you paramedics doing whatever you're doing across the world, is you are awesome. You're doing an amazing job, and keep inspiring us and keep pushing parameters. Boundaries are there to be pushed aside, and for paramedics to really to become what they really can be in any region. So finally, just a huge thank you to all the participants and all the speakers for such a great event. It's been a tremendous symposium. So thank you.